So I'd like to welcome you on behalf of a group of European myeloma experts who came together here in Paris, France, to discuss the current treatment practice in multiple myeloma. And we would like to give you our notion on the current standards. So the old paradigm still holds true. Young patients who are fit and eligible for a transplant should receive transplantation, and when you start transplantation, I'm afraid, then you have, of course, to ask the question which regimen is appropriate, and the consensus was that 3 to 4 cycles of a bortezomib-based regimen should be applied. And there are different options which are available. You can go with VTT, VCT, PAT, VCT, and VRD. And the regimen which you see on the slide, which P and Asterix have been tested in phase 3 trials against other regimens and have shown superiority against others. But all of them are probably appropriate for induction therapy. And the consensus is that after 3 to 4 cycles, patients should be submitted to transplant. After transplant, we have several options. Number one, wait and see, or you may wish to discuss with your patient consolidation and or maintenance therapy. At the time being, there's no clear recommendation, no clear standard for both approaches, but I think it's worthwhile to discuss the pros and cons of, for instance, consolidation, which means it is a short treatment trying to improve the quality of response. So it's a treatment including 2 to 4 cycles of therapy. You could use a second transplant, and there are data which have shown that that is feasible and is particularly useful in patients who have not a very good partial response. You can use VTT, VRD, bortezomib-based regimen or lenalidomide-based regimen, and all these regimens will induce a higher response quality in a significant number of your patients. These better responses are likely to be associated with longer progression-free survival. There will be more patients who achieve molecular remission. The maintenance approach is, as you know, an approach where you give treatment in order to maintain the results of induction therapy for as long as possible. And we have 3 candidates which have been tested and which are presently tested in clinical trials. It's thalidomide. Thalidomide has been shown to increase progression-free survival, and when you look at all data which have been gathered, when you do a meta-analysis, also to improve overall survival. But there are, of course, certain limitations with this treatment, particularly in patients with poor risk cytogenetics. Thalidomide should not be used because of unfavorable results, and you all are aware of the side effects which thalidomide may induce. And most trials use thalidomide for a couple of months, some of them for longer than 1 year, but as you know, tolerance is limited, and so it's not clear what is the optimal duration, but usually 1 year should be a feasible duration of treatment, and low dose should be selected, maybe 50 to 100 milligrams. With lenalidomide, you have heard about and read about these results, excellent results in terms of increasing the progression-free survival in patients after transplant. And the increase is outstanding. It's 22 months or more in both trials. And the problem is that we have not enough long-term follow-up data. You know that lenalidomide has improved overall survival in 1 trial, but not in the other trial. And there's still a question mark regarding the second primary malignancies, which are more frequent with lenalidomide than with control. Bortezomib has been tested, and there is this interesting HOVON trial which use bortezomib in the induction phase and in the maintenance phase, as compared to a control with thalidomide, and bortezomib induced longer progression-free survival and longer overall survival. But we have to acknowledge that bortezomib was not only the maintenance treatment, it was also used in the induction therapies. So we have to wait for other trials, which are likely to mature soon. In patients who are not eligible for transplant, in elderly patients or in patients, younger patients with comorbidities or patients who opt for conventional therapy, you have several options. You can use VMP. You know about the excellent results of the VISTA trial, which has shown high efficacy in terms of response rate, progression-free survival, and overall survival in all risk groups. So this is very efficient treatment regimen, also for elderly patients, very well suited. MPT has been tested in 7 prospective randomized trials, and when you do a meta-analysis, you certainly observe an improvement in progression-free survival against MP and an improvement in overall survival. But this regimen has some limitations, which are mainly due to thalidomide. You can use cyclophosphamide instead of melphalan, and that has been nicely shown by our colleagues from UK in their MRC trial. So these are very valuable options. You can also use, and we are well aware of the frequent use of Revlimid dexamethasone by our American colleagues. There is one study, as you know, the ECOG study, which has shown that Revlimid in combination with low-dose dexamethasone is superior to Revlimid plus high-dose dexamethasone. And we have trials from Europe using VMPT followed by VT, using VMP followed by VT, MPR followed by R, and in Europe, bendamustine prednisone is approved for first-line therapy in patients with multiple myeloma and has been shown to improve progression-free survival as compared to melphalan prednisone. Now, when your patient comes in after successful treatment, after hopefully a very long honeymoon of excellent maintenance time, then when he comes back with relapse, you have several choices. If the patient has been treated with frontline, including frontline therapy, including a novel agent, and if the time between first treatment and relapse is very long, and if the response to this regimen was very good and was well tolerated by your patient, then you have, of course, the option to reuse this regimen, and that has been shown, for instance, in several trials, that you can then achieve good response rates. If the time between first-line treatment and relapse is short, you have to switch to another class, and then you have several options. If the frontline treatment consisted of an IMiD-based regimen, then probably you would opt for a bortezomib-based therapy, including bortezomib-dex, bortezomib liposomal, doxorubicin, VCT, BAT. But you can also use bendamustine, and you can enroll your patients in clinical trials. If the patient was exposed to bortezomib, you will probably opt for an IMiD-based regimen, like Lendex, CRD, Taldex, CTT, but also bendamustine would be an option, and of course clinical trials are always an important and interesting option. So let's move on. If the patient has not been exposed to a novel agent during frontline treatment, then you have the option to use one of these novel agents, either to go to an IMiD-based regimen or a bortezomib-based regimen, or a combination of IMiD and bortezomib-based regimens, and you can use other options which are becoming more popular in Europe, like bendamustine plus other drugs, particularly in combination with bortezomib. So there are several options available, and I think that is already the last slide regarding the standard treatment recommendations. Now we have new drugs on the horizon. Carfilzomib and pomalidomide will be approved soon in the US and will be available in the US. These are drugs which have very high activity in patients pre-exposed to several drugs. So these may be very good choices for second and third line treatment in combination with dexamethasone or other drugs. And of course, there are many trials with novel agents. There are trials combining established drugs with antibodies, and one of the attractive antibodies is elotuzumab. So combinations between elotuzumab and established regimen seem to be highly attractive, and there are many other trials. So in the future, one may even envisage the same lymphoma-like treatment in some patients with myeloma using an antibody plus chemotherapy and hoping for better outcome, better response rates, better progression-free survival, and better overall survival. With that saying, I would like to lead over to Professor Tanos Timopoulos from Athens, who is going to open a discussion round on another issue, namely, I think, the question whether response, depth and response is important. Thank you very much.
Over the last decade, we have seen that the outcome of the patients with myeloma is improving, and this affects both younger patients who receive high-dose therapy and also older patients who are being treated with novel agent-based regimens. However, there is still a question whether there is a correlation between response and outcomes in multiple myeloma patients, and more specifically, whether we should aim to achieve a complete response, how we define complete response, and what is the impact of complete response. In this diagram, there is a theoretical correlation between depth and response and time to progression, and eventually with overall survival. And it is our clinical impression that patients who achieve a very good partial response or a complete response, they tend to have a longer time to progression, and probably this translates to a better survival. Over the last years, there have been several changes in the definition of response. Here we have the International Myeloma Working Group 2006 definition of response. In this particular table, we see that we have the very good partial response included in the response criteria, and even more so the stringent complete response, which requires not only criteria for complete response, but also a normal free light chain ratio and absence of clonal disease by immunohistochemistry or by immunophenotype. More recently, Raskumar and colleagues reported a consensus paper from the International Myeloma Working Group. In this particular paper, minimal response was included, especially to assess activity of novel agents in patients with relapsed refractory myeloma, and immunophenotypic response was confirmed as a necessary tool to assess the stringent complete response, and also molecular response was also defined. Based on these changes and on several new treatment paradigm that we have for myeloma, it is my pleasure to have several colleagues who are experts on myeloma treatment, and we could discuss several aspects concerning the impact and the definition of complete response. And I would like to start with Dr. Hess and to ask him what is the evidence that complete response is important in younger patients with myeloma who undergo induction treatment and high-dose therapy?
For these patients, we have data that the achievement of a complete remission is associated with a prolonged overall survival. And we know that the achievement of a very good partial remission is no longer a sufficient therapeutic goal, but we need to have a clearly defined complete remission in order to have a prolonged progression-free and overall survival.
Okay, and then regarding older patients with myeloma, we have today more effective regimens, and now we have 30 or 40% of patients who are included in clinical trials who may achieve a complete response instead of 5% of less 10 years ago. So is there an evidence that the depth of response correlate with the outcome in these patients, Dr. Lucio?
Yes, I think considering complete response as a surrogate marker of outcome is still valid also for older patients. Nevertheless, as we move for older patients with more frailty, we should be careful to consider also the comorbidities that those patients have. Nevertheless, the recent studies that include older patients, like the VISTA study or the MPR, found that complete remission is still associated to a better outcome.
Thank you. The situation is more complicated in patients with relapse refractory myeloma, and not only because these patients tend to have low rates of very good partial response and complete response, but also usually the time to progression in those patients is much shorter. Dr. Ludwig, do we have evidence that correlates depth of response with outcome in this particular setting?
Yes, the answer is clearly yes. There's a close correlation between the quality of response and progression-free survival, and this seems to translate also into better outcome in terms of survival. And in addition, patients who enjoy an excellent response, good quality of response, complete response, are usually free of symptoms of their disease. So that is the goal. Of course, we have to balance that against the toxicity of therapy.
Thank you. Traditionally, we are using serum and urine electrophoretic studies to evaluate myeloma response, and also we want to have a better look at the bone marrow of the patients in order to assess the depth of response. Dr. Davis, can you guide us through the impact of immunophenotypic complete response and molecular complete response that have been used more recently to assess and to define stringent complete response?
Yes, as you say, there's two tests which are now used in a lot of the large studies. These are flow cytometry, where you can measure one tumour cell in 1 to the 10 to the 4 or 10 to the 5 normal cells, or a PCR technique where you can measure one tumour cell in 10 to the 6 normal cells. Both of these techniques have been shown to be good prognostic markers, so you can identify patients who have a good response, but and then have a prolonged survival. However, some of the difficulties with the test is they maybe need to be done in more specialized laboratories.
Thank you. And of course, myeloma is unique among the hematologic malignancies because it affects the bones, and we know that this is a major cause of morbidity, and it would make a lot of sense to assess response not only in the bone marrow and in the serum and the urine, but also to evaluate bone response. Dr. Cavo, your group has published recently several papers in prestigious journals regarding the role of newer imaging techniques such as MRI and PET-CT in assessing response, and also the prognostic significance of this assessment in the outcome of the patient. Can you give us a summary of your most recent findings?
Yes, both MRI and PET-CT are functional imaging techniques which can more carefully evaluate the bone and marrow involvement in myeloma patients, can provide useful prognostic informations, and based on recent data can also be applied to more carefully refine the definition of conventionally defined CR. In particular, two independent trials showed that the patients in conventionally defined CR could be substratified into two groups with different clinical outcomes according to the negativity or positivity or MRI or PET-CT after transplant. Therefore, it is likely that these new functional imaging techniques are able to investigate the presence of minimal residual disease not only at the bone marrow level but also outside the bone marrow. Obviously, at this time, we have data showing that patients in conventionally defined CR are not a homogeneous population, similar to what was previously demonstrated by using flow cytometry. The next step is to investigate if different treatment strategies can modify the outcome of those patients in conventionally defined CR with persistent MRI or PET-CT positivity.
Thank you. It is clear, I think, that today we have much more sensitive tools to assess complete response of the myeloma to the current treatment. And I think that these newer techniques not only give us prognostic information regarding the outcome of the patient, but may provide, as you mentioned, the basis to conduct prospective trials and see whether treating patients who have residual disease by flow cytometry or by PET scan may improve patients' outcome. I would like to thank you very much for this discussion.